Hi everyone, thanks for joining the National Headache Foundation for our latest webinar. I want to start by introducing and thanking Dr. Sarah Rahal. Dr. Rahal is an assistant professor of neurology and pediatrics at Mount Sinai. She's a board-certified neurologist, also specialized in headache medicine. Today she will give her presentation, College Bound with Migraine. Dr. Rahal, whenever you're ready.
Hi, I'm Dr. Rahal. I'm a pediatric neurologist and headache specialist. Today we're going to talk about being college-bound with migraine. So the basic things that we'll cover today: what exactly is migraine? What are common lifestyle triggers for migraine, and what unique challenges presents in the college environment? What can you do to mitigate these triggers? And we'll address the importance of seeking medical care for migraine management. So what is migraine? Migraine is an inherited tendency towards headache. So it's an underlying predisposition that's genetic, so it tends to run in families. And we think of it as a threshold phenomenon. So in a susceptible individual, in the setting of enough triggers, a headache may be triggered. It's usually the final trigger that's the most obvious, but the underlying ones are just as important. For example, if you stay up late, you may not always get a headache, but if you stayed up late and then went to take a particularly stressful exam on an empty stomach, you got dehydrated and drank lots of coffee to keep going, the attack is more likely. So all of the triggers contribute. These are the criteria that a doctor looks at when making a diagnosis of migraine. So it requires at least 5 attacks fulfilling the following criteria. So it's headache pain that lasts between 4 and 72 hours. The headache has at least 2 of the following criteria. It's either one-sided, it has a pulsating quality, it's moderate to severe in pain intensity, and it's aggravated by routine physical activity like running or bending over. It must have at least one accompaniment, either nausea and or vomiting, or light and sound sensitivity. So migraine in children and adolescents has some distinguishing features. Firstly, it may be shorter, so it may be as short as 30 minutes. And it's more common in children and adolescents for the headache to be on both sides of the head rather than just on one side. So why isn't it just a tension headache? So this is often what people come into my office thinking. While tension headaches are strikingly more common in the general population, as you can see here with a lifetime prevalence of 80%, they are by definition mild to moderate in intensity. So people with tension headaches typically do not see doctors for their headaches. They self-treat at home. So headaches presenting to primary care doctors' offices are almost always migraine. Also, why isn't it just a sinus headache? Migraine is commonly associated with forehead and facial pressure over the sinuses, with nasal congestion, with runny nose, so it's no surprise that this is a common misdiagnosis. There was a study done in 2004 showing that 90% of the time, self- or physician-diagnosed sinus headaches were actually migraine. This was an additional study looking at migraine patients and something called cranial autonomic symptoms, which are things like fullness in the ears, nose running, nasal congestion, teary or swollen eyes. And the study found that 73% of children with migraine had some such features with their headache. So in the absence of fever or pus from your nose, that headache is most likely migraine. So if you're listening to this webinar now, the chances are that you or your child has migraine. When I tell people what I do, I'm often met with, kids have migraines? Yes. In fact, 20% of migraine patients have their first migraine headache before the age of 5. This chart depicts the lifetime prevalence of migraine. If we were able to zoom in on the early part of the graph here, we would see that actually from infancy to age 7, boys are affected slightly more often than girls. typically starting around age 7 in boys versus 11 in girls. After the first menstrual period, a female predominance occurs, and this continues to increase until middle age. And migraine decreases in both sexes after age 50. So the prevalence of migraine in kids is about 10% for kids 5 to 15 years old, and then 28% for adolescents. This is a common problem for teenagers approaching college. So going back to our initial premise, you have a threshold above which a migraine is triggered. What exactly is happening? This represents our current evidence. It's not fully understood why migraine occurs, but this is what our data suggests. So in a susceptible individual, in the setting of enough triggers, a cascade of chemical activity is initiated. The phenomenon is called cortical spreading depression, and that's believed to be the underlying step. It's this wave of electrical activity that propagates along the outer layers of the brain, followed by a wave of suppressed activity in the nerve cells. This phenomenon explains aura in those individuals who have migraine with aura, which is typically a visual phenomena that precedes the onset of headache. And this wave of electrical activity additionally activates the trigeminal nerve, which is the nerve that mediates sensation around the head and the face and activates pathways at the base of the brain. This leads to activation of and changes in the blood vessels, waves of electrical activity, and inflammation, which releases chemicals, all resulting in the head pain and the other associated symptoms of migraine like nausea and light sensitivity. A very complicated process. So I want to turn our attention again here. What are these triggers that can set off this cascade? And so where can we intervene? One study showed that the average number of triggers for an individual migraine patient was 7. Note, stress is the #1 trigger in about 80% of patients, followed by lack of sleep, warm climate, video games, etc. These other major categories involve an overall change in the rhythm of the day. Hormone changes, not eating, sleep changes, perfume, smokes, odors, neck pain, light, alcohol, smoke, sleeping late, hot, humid weather, sun exposure, exercise. It's exhaustive. Migraine patients should be creatures of habit. The college environment can be particularly challenging in this regard because the patterns of the day may vary and teenagers are removed from the usual routine they have had at home. Many of these factors are not in our control, so it is very important to do the best we can with the triggers we have control over. So equipping college students with this knowledge can set them up for success in the college environment. I want to focus specifically on those triggers that we have control over. So sleep. 15 million American children do not get enough sleep. Particularly note the number here in teenagers. You should be getting 9 to 10 hours a night. Most only get 7. One of the most common patterns of headache that I see in teenagers and that continues through college is a Monday-Tuesday headache pattern, which results from a combination of sleep changes over the weekend, with teenagers, particularly in college, staying up late and sleeping late, then needing to go to bed earlier on Sunday to wake up for classes on Monday. So it's the consistency that's important. Same time to bed, same time to wake, even on the weekends. Should avoid caffeine and screens, no daytime napping. There should be 30 to 60 minutes of wind down time before bed. This may mean altering the schedule, taking advantage of classes that start late on Monday. The roommate situation may pose particular challenges, particularly for sleep, because students with roommates, the sleep schedule may not be fully within their control. So it may be useful to have set rules with roommates about lights off time, no visitors past a certain time. Rooming options certainly vary widely at colleges. In severe cases, it may be appropriate to request a single room, allowing for exclusive control over the environment, and your doctor can write a note requesting this if need be. This is particularly useful in teenagers with severe migraine. Hydration. So I hear of dehydration as a trigger frequently. There was one formalized study actually looking at this. They took 102 headache patients and randomized them to either increasing their water intake by 1.5 liters a day or counseling. The water drinkers had a significant improvement in their migraine disability. So goal hydration is 1.5 to 2 liters of non-caffeinated fluid daily. That's 3 to 4 regular-sized water bottles. Make it easy. Get a thermos to carry around. I push this particularly in headache patients who have a lot of associated dizziness and vertigo with their headaches. Let's turn to diet. So again, consistency is key. There was a 2012 study that took 800 adolescents, and this showed that headache tended to happen in those who irregularly consumed meals, particularly breakfast. And those teens who skipped meals more often had greater headache frequency and disability. About half of migraine patients report fasting as a trigger. So small, frequent, nutritious meals is probably best. The advantage of campus dining halls that are open 24/7 is that food is always accessible. However, the accessibility doesn't necessarily encourage regularity in the eating schedule. So it's important to pay particular attention to this. Another downside is that many times the food halls discourage students from taking food outside of the dining hall. So particularly when scheduling is an issue, if there's no time before the first class in the morning to sit down for a meal and have breakfast, it's important that college students have something with protein and carbohydrate that's easily available to them in the morning. Yogurt, granola, a protein bar, make it easy, keep it in the dorm room. Keep the dorm room stocked with this stuff. Depending on the study, anywhere between 7% and 44% of people have some food as a headache trigger. The most common tend to be cheese, chocolate, and citrus fruits, but again, these are not triggers for everybody. So eliminating all of these foods is not advisable. It just leads to nutritional deficiencies and makes it harder to find food, which in and of itself can be a trigger. So any food can really be a trigger. These are just common ones that are reported. So keep track. See if this is the case for you. If so, this can be an easy thing to address. Aspartame. What to know about this ubiquitous sugar substitute? So there have been several studies looking at this, demonstrating an increase in headache frequency in migraine patients who are exposed to aspartame for 2 to 3 weeks. This is particularly when the exposure is prolonged. So be aware of what's in your food and beverages. These sweeteners are hidden everywhere, and it may be a trigger. Along these lines, the habit of gum chewing may also trigger headaches. This was a study looking at 30 patients with chronic headaches and daily gum chewing. With cessation of gum chewing for 1 month, 26 out of 30 patients had significant improvement in their headaches, and more than half became totally headache-free. So something to think about. Adolescents in particular drink large volumes of caffeine-containing drinks daily. Girls may use Diet Colas as substitutes for food. College students may drink excessive coffee or energy drinks to stay up studying for exams. Caffeine's in a lot of products people don't even think about, like iced tea or medications. One study looked at adolescents with daily headaches who were using more than 200 milligrams of caffeine a day. So for reference, a small cup of home-brewed coffee is about 100 milligrams, and a grande Starbucks is 550 milligrams. So 200 milligrams is like 2 cups of regular strength coffee. So in this study, they tapered caffeine intake over 2 weeks. and almost all of the patients had complete cessation of their headaches. So caffeine's good and it's bad. It's present in a lot of over-the-counter medications for headache. So in those who aren't chronic users, it can actually be beneficial at relieving headache. But for those who use more than 200 milligrams of caffeine a day or more, they're at risk of withdrawal headaches. This is particular for people with migraine. So max daily caffeine should be no more than 200 milligrams a day. So reach for a Gatorade instead of that fourth cup of coffee during study hall. Really keep a close eye on this. So how do you figure out what your triggers are? The headache diary is key. Marking down any day with headache and the circumstances around it, weather, sleep change, stress, or otherwise. It can be done on paper. It's easy for teens to just track this in their phones. There are some great apps to help with this. The headache diary also serves another useful role. It can help your doctor decide what treatment may be most appropriate. If there's been an unexplained change in the pattern of headache, your doctor may want to run more tests. So even if you're doing everything right, there are times when you will get a headache. The most important thing is to have a plan in place. So talk to your doctor early. In general, when it comes to migraine treatment, there are two kinds of medications that are used. Abortive treatment is the medication you take to terminate a new headache. These are things like ibuprofen, naproxen, the triptan medications. They should be taken early in the headache and aggressively. The later into the headache you treat, the less effective any medication is. So this is an important thing to keep in mind. For those with more frequent headaches, your doctor may decide that preventive treatment is indicated. This may include daily medication, but other options include things like vitamin supplements, physical therapy, biofeedback, addressing comorbid mood disorders, acupuncture. The goal of these preventive treatments is to make it harder for the brain to generate the headache in the first place, essentially helping to raise that migraine threshold. So when to initiate preventive treatment, in general, is a discussion with your doctor, but it's typically done when there are more than 5 headache days a month. So it's important to meet with your doctor and discuss this early because the medications can take about 2 months to start taking effect, and it may require trial and error to find the correct regimen. Another important thing to mention is something called medication overuse headache. So this is a complication of frequent headaches. When headaches become frequent, if you just continue to use your abortive treatment for every headache, just keep popping that ibuprofen, you may end up with more and more headaches as a result because of a rebound phenomenon. It's similar to what happens with caffeine, like we discussed earlier. This is called medication overuse headache. So initiating preventive treatment is essential for college students with frequent headaches to prevent this vicious cycle. It can also break this cycle if it's already started. When medication overuse headache develops, it can massively interfere with functioning at college, and migraine sufferers are uniquely predisposed to developing this. So in general, as a guideline, abortive medication should not be used more than 10 days a month. So in conclusion, for those teenagers with migraine, the strategy for transitioning to college is threefold. So number one, it's about anticipating the lifestyle changes college will bring, primarily a loss of structure. There's additional stress that comes with living independently and tackling academic challenges. You may go long periods without eating or consume less nutritious foods. There may be a loss of control of the sleep schedule that comes with a shared living space. You may have less time to exercise, etc. Number two, recognizing your individual triggers for migraine. So a diary is helpful to elucidate this. Look for trends, changes in your pattern. Focus on avoiding those triggers that are within your control. And number three, having a treatment plan in place. So speak with your doctor. You should have abortive treatment that you can reliably take to terminate a headache and prevent it from interfering with the day-to-day of college life. And if necessary, a plan for preventive treatment to make frequent headaches more manageable. So with these tools, migraines can certainly be managed in the background, allowing you to fully participate in the college experience. I'm happy to take questions. Thank you.
I'll give everyone a couple of minutes to get some questions, but I have one. And so I'm curious, when you're seeing a high school student, when do you kind of start maybe planning in advance? Because I'm sure some of the diaries and some of the things that they can do to recognize their triggers is a lot more helpful if they have, a year or two of data as opposed to just, a couple of months out. Now they start worrying about it, and it can be difficult to get all that information that quickly. So when do you kind of start preparing them for if they are going to go to college to start looking into it?
Absolutely. So great question. Start the headache diary as soon as possible. So the first time I see a patient, or even when I know that a patient is being referred to me, I tell their pediatrician or their primary care doctor to have them start keeping a diary, because the more data and the more time points you can look at, the better you can gauge what kind of treatments might be most appropriate, and the better you can gauge when changes happen in the pattern of headache and you might need to modify what you're doing. So diaries are things I start keeping as soon as I see my first patient. So even as young as 3-4 years old, I'm having the parents keep diaries to try to figure out how often the kids are having headaches. The sooner the better.
And I had a question in from, it sounds like a worried parent who says their son struggled with it last year or the freshman year, and maybe that second year, kind of hoping it gets a lot easier once you kind of know what you're in for, and you can kind of plan for those triggers. Have you seen people be more successful kind of once they're in their second, third year, and they at least have a little bit better idea of what they need to do?
It's certainly possible. As people get better at managing their headaches, they may, things may improve, but there's always going to be stressors and changes in the college environment, so I am never one to kind of risk it. I like to make sure that there's a plan in place so that if things do start escalating or things are not improving, we can intervene as soon as possible. Like I said, the preventive strategies take quite a bit of time to really start taking effect. So once you know that things are on the wrong track, it's best to intervene sooner rather than later.
And kind of going back to triggers, have you noticed any triggers changing when they are in school and they are in a different environment, that maybe some things either fade away or maybe there's a new trigger pops up?
Sure. Sometimes the triggers aren't so obvious before college, and then when things are kind of pushed to the max, you can become much more sensitive to individual triggers. And like we saw in the early slides, it's a threshold phenomenon. So there's not just one trigger that's going to reliably give you a headache every time, but if you're in a college setting and you have a lot of underlying triggers going on a regular basis, there might be other things that weren't a big deal before, but now they're kind of tipping you over the edge. So keeping track with a diary helps you be aware of all of those things that are contributing to your trigger pool.
All right. That looks like that was the last question. So I just want to thank everyone again for joining us tonight and sending in a few questions. Dr. Rahal, thank you for your time. We really appreciate this. We will, like we do with all of our webinars, we'll put this up on our website as soon as we have a chance to do that, hopefully in the next couple of days. So if you know anyone that may find this useful, it'd be great to pass it on, because there's a lot of great information there. So thanks again, and I hope everyone has a great night.
Yes, good night to all. Bye-bye.